Good morning, good afternoon, good evening, or good night, whatever time it is, wherever you are. Welcome to I Can't Take All This Science. This is Dr. Brian Novi, and I know that I've got a bunch of friends on the phone and probably some friends that I don't even know I have yet that will be my friends after the end of this. So thank you, everyone, for joining me and giving me a little bit of time this evening to chat about tooth decay, caries, remineralization, CPP, ACP, protein, and kind of bring you up to date on where all the science is with remineralization. We're in a completely different place than I thought we would be, I don't know, even 5 years ago. And so it's just exciting to me where we are with all the different topical therapeutics we have to treat tooth decay. Before I go any further, I'm sure it's no surprise to anyone, tonight's presentation is sponsored by GC America. And if you know me, you know that I like to tell you all the manufacturers that sponsored me throughout my career. So just be aware that I've been paid by other companies like Straumann, Shofu, Clear, Solution Reach, Air Techniques, Carry Free, Philips, Ivoclar, Trident, SDI, Voco, GlaxoSmithKline, Mars Wrigley, Church and Dwight, United States Department of Defense, Loma Linda University, DentaQuest, and the Massachusetts Public Employees Fund. I have faculty appointments at 2 dental schools, and I am a strong proponent of probiotics, but I don't usually talk about them. But I am a fan of ProBio or probiotics. I don't receive money from them, but I did do clinical research for them. All the pictures of my presentation are my own, except for a few that I have made with AI, like the title slide I made with AI. I'm getting more and more used to using AI nowadays, but I haven't photoshopped anything because I can't figure out how to use that software just yet. And I know you're all very excited about this, but there's going to be a quiz at the end so you can get your CE credit. There are 5 true or false questions. I have them all here in front of me. And as I go through this webinar tonight, if you see a yellow star on the screen, I would pay particular attention to that concept because that is going to be one of the 5 true or false test questions. So you should only see 5 yellow stars throughout the presentation. Each one of those corresponds to a test question. So let's get going. Let's talk about your handout because I know you're all going to want to follow along in your handout, which you don't have one because I'm a tree hugger. You're going to have to go online to a website and find my handout. And probably the best handout I have is a paper that I wrote for the Journal of the Michigan Dental Association. And it was published under the title Minimizing Aerosols with Non-Surgical Approaches to Caries Management. If you come to one of my actual lectures, I will give you the galley proof of this article. I thought it was going to be published under the title Codependent Cariology, but apparently nobody thought that title was engaging enough. So they went with Minimizing Aerosols with Non-Surgical Approaches to Caries Management, which clearly is a gripping, riveting title. And everyone went running to read that paper because it was much more exciting than Codependent Cariology. I'm being sarcastic for those of you who don't know me. But anyway, with all that said, go do a Google search for Minimizing Aerosols with Non-Surgical Approaches to Caries Management, published in the Michigan Dental Association Journal, and you're going to get a paper that has this table in it. And this is probably the best handout that I have. Actually, it's not the best handout that I have, but it's probably the most succinct handout that I have of how would I treat caries medically in my office? What do I reach for remineralization? Of course, if you know me, you know that my recent mantra in my lectures is really I've made this too complicated over the years, and it should not be about therapeutics. It really should be about changing patients' behaviors, because really at the end of the day, if we don't get our patient to brush a little bit better and understand that they are in control of the most preventable and prevalent disease on the planet, if we can get them to understand that concept, we're going to go a lot farther in actually preventing disease in the future for them. If we make it all about the one therapeutic they can get to us in this one visit, what happens if they can't get that therapeutic, if we don't teach them those healthy habits? And so please, if you take nothing else away from tonight's presentation, it's not about the therapeutics. We've got great therapeutics that taste amazing. GC America makes some of my favorites. You'll know that before the end. Anyone who knows me knows I'm a huge fan of MI Paste. It will always have a place in my practice. And now that we have MI Paste 1 for kids, and then, plus I'm going to talk more about MI Paste Perio tonight, which up until recently, I really didn't appreciate just how important MI Paste Perio is. But from a standpoint of remineralization and preventing acid dissolution of the tooth, we really need that stannous ion. So I'm going to talk more about that tonight. That's not a quiz question yet. I was just talking about the handout. Oh my gosh, we're 5 minutes into this. We're still just on the handouts. But the better handout that I have, the one that I think you're definitely going to want to read right now. In fact, don't do it right now. I'm going to tell you all about it, but you're going to want to read and you're going to want to run and do it right now. But please don't. I want you to do a Google search for, write this down, ASTDD space BPAR space ECC. So that stands for the Association of State and Territorial Dental Directors Best Practices Approach Report on ECC, Early Childhood Caries. And I have come pretty darn close to writing a PhD dissertation. I call it my manifesto. And I have been traveling around the United States, putting this document into the hands of policymakers, saying, if you don't have a state dental director, here is what I think you should be doing to actually prevent caries better in kids. And I actually talk about these novel reimmunization agents that tonight's webinar is all about. So those are my 2 best handouts. They're available for you online. Minimizing Aerosols with Non-Surgical Approaches to Caries Management, published in the Journal of the Michigan Dental Association, has that table of all the different products I like to use. And my better handout is the paper that I wrote for the Association of State and Territorial Dental Directors. And that's my best practices approach report on how to treat caries medically in children. With that being said, it's all about what is going to fit into our patients' routines. So please don't make this about when do I know when to give which therapeutic. The most important thing you can do for your patients is understand what's going to fit into their routine. If you give them a therapeutic that doesn't fit into their routine and they can't actually use it, it's not going to be successful, which is probably why mouthwash that tastes like crap always shows in the literature that it doesn't work, because what chance are you going to have to get a patient to use a mouthwash that tastes like crap if they don't want to taste? I probably shouldn't be saying it like that. I got in trouble early in my career for using moderate language in my lectures, and I'm realizing now that there's no one here to muzzle or filter me, and so I apologize if I use the C word out of turn. But the point I'm trying to make is, please make sure that whatever therapeutic you offer your patient is one that they actually want to use. And please don't be that clinical provider who says, I don't like the way that stuff tastes. It's not about you. It's about your patient. And so ask your patient if they like the way it tastes. And believe it or not, some patients like the way things taste that you don't like the way things taste. Like, I don't like sushi. Some people like sushi. So, or I shouldn't say that. Those of you who know me, I like sushi. I just don't like freshwater eel sushi. So, everyone has different tastes. And too often, I believe that we hinder patients from getting really effective therapeutics because we don't think they work. Well, you don't necessarily have the same problems that your patient has. So don't make this about you and your likes. Make it about what does the patient like and what can the patient actually use. Is it easiest for the patient to switch out their toothpaste? Is it easiest for them to use a gel? Is it easiest for them to use a mouthwash? How about if they use a spray? Is it easiest for them to change their diet and never eat sugar again? Or is it easiest for them to use some gum, some lozenges, some mints, suck on some candy a couple times a day, drink their soda through a straw, brush their teeth on the way to and from work in the bathroom, brush their teeth on the way to work in the car rather than in the bathroom only at night before they go to bed? We can get really creative with our oral health messaging, and that's what I'm going to encourage you all to do on the call tonight. But you obviously want to reach for some evidence-based clinical practice guidelines, and so I would be remiss if I didn't share with you the JADA Evidence-Based Clinical Practice Guidelines on Non-Restorative Treatments for Caries Lesions, a report that I helped write for the American Dental Association, which is based on a paper that was published in the Journal of Dental Research, where we actually did a network meta-analysis on the non-restorative treatments for caries lesions. And it was a systematic review, and it won a Guy's Award from the most influential paper in the literature that year. Now, if you want some better handouts, you can go to my website, www.holymolar.net. That's WHOLLYMOLAR.net. Don't use .com because for some reason .com is not working right now. So use .net. And when you go to my website, I've got a bunch of handouts on there. I would recommend that you come to my lectures though before you just go clicking around on my website, because most of the handouts are far too advanced for you at this level. If you're only just listening to my first webinar right now, please don't read the handouts on my website. They're far too advanced. Just kidding. I think you'll like them. Anyway, this is where cariologists live. We live in the world of two inverted right triangles, where we don't want our patients to develop periodontal disease, and we certainly don't want them to develop caries. But realize that these two diseases live at opposite ends of the spectrum. If your patient is prone for periodontal disease, they are not prone for caries, and vice versa, because these two diseases live at opposite ends of an ecological spectrum. Now, if you ask me, well, how do you explain cariology to dental students or to anyone in the oral healthcare community? This is how I would describe it. It's a very complicated chain link fence. We all know it's a multifactorial disease. Notice the yellow star down there. So the yellow star correlates to one of those bacteria over on the left-hand side of your screen. So you're going to want to know, what is the latest and greatest cariogenic bacteria? Well, there are lots of bacteria that cause caries today. Now, you may have been taught in school that's Streptococcus mutans and lactobacillus cause caries. Well, sorry to tell you, no, that's not true. They're involved in the process, but today the prime etiologic agent that I've got my sights on is called Selenomonas sputagina. And now I'm realizing I actually spelled it wrong in the test question at the end of the webinar. So don't get hung up on the spelling of the bacteria in the quiz question. I apologize. But Selenomonas sputagina is this really cool bacteria. It's one of the first facultative anaerobes that we know is involved in the process. And that facultative anaerobe has a tail. Some might call it a flagella. I call it a tail. But this little bacteria is responsible for increasing the virulence of the biofilm and making it super sticky and porous and allowing it to concentrate those bacterial acids down on the teeth. So Solenomus pseudogena is our new carriogenic organism that everyone is trying to research and learn more about. But we have this whole array of carriogenic bacteria that feed into the process, and they have to live in your mouth for a period of time. And the good commensal organisms like Streptococcus sanguinis and Streptococcus dentisani, those bacteria have to leave your mouth. And this whole thing is driven by poor saliva and diet and hormones. And so if you have a chance to come to one of my actual courses where I talk about this live, I will go through this diagram in much greater detail. But tonight, I don't want to spend that much time on it because I want to get into more of the therapeutic stuff that we're talking about. And I've been practicing for about 18 years now, and I've been really fascinated by karyology and tooth demineralization, so much so that I'm one of the few dentists that's been able to actually use technology like the Canary laser. We're the first office in the United States to get the new Calcivis technology, which allows us to use a photoprotein and image teeth with photoproteins to actually see calcium leaving the tooth. And it's so exciting for me to be able to have conversations with patients to say, dude, look, do you notice your filling is literally melting in this picture? And then they say things like, well, so what do we do? Now, the moment I know that a patient is asking me, what do we do, is the moment I know that we can convince that patient to actually change their behavior, because they're asking for our advice. So often we just offer patients advice without actually seeing if they want it. And I'm going to talk a little bit more about that. So as I measure caries lesions in practice, one of the things that we've always had a hard time doing is actually being able to remineralize the body of the lesion. And you'll remember from your karyology coursework in whatever training program you went to, that the most well-mineralized part of the caries lesion is actually the outer layer of the lesion, the surface zone. So many of us think of caries like acid erosion, where the acid on the outside of the tooth just eats away at the tooth. And that's really not what happens in karyology. What happens in caries is the inside of the tooth is sacrificed, and the ions move from inside the tooth up to the outside surface of the tooth, where they come into contact with the pellicle and the biofilm. And there's this remineralization, demineralization phenomenon that's occurring just below the biofilm, right where the biofilm and pellicle and enamel interact. And it's that surface zone that can impede our remineralization or allow us to actually achieve remineralization of the body of the lesion. If that surface zone is actually gone, we can drive ions deeper into the body of the lesion. So some protocols will actually tell you, well, remove the surface zone with something like enamel microabrasion. And if you're using some of the new P11-4 scaffold technology, you'll know that we want to remove that surface zone so we can get the self-assembling peptides into the body of the lesion. So it's that surface zone, though, that actually tells us, dude, you can totally remineralize these things, and they remineralize from the outside in. And if we focus on the fact that under biological systems, the biofilm is our remineralization agent. If it's a healthy basic biofilm, that biofilm will hold excess calcium and phosphate on the teeth. Our job as clinicians is to enable patients to understand, how do I get that biofilm super saturated with calcium and phosphate? I know most of us have made our entire career about getting the teeth squeaky, squeaky clean. But come on, people. We realize that even the best brusher takes at least 25 minutes of brushing to get their teeth squeaky clean. So we're leaving behind at least a couple cell layers of biofilm and bacteria on our teeth. And if you're leaving behind acidic biofilm, well, you haven't done anything to actually shift the Riemann-Diemann balance. And so that's why what I love about the CPP-ACP molecule that's in GC technology, you have something that actually helps bind calcium and phosphate to these sticky plaque matrices, like a karyogenic biofilm. And our sticky products, like casein phosphopeptide, that sticky goo that holds calcium phosphate on the teeth, allows calcium phosphate to slowly be released. And one of the things I'm going to talk about later in the presentation is, if we've learned anything from remineralization lately, it's that you want to slow it down. The slower you do the remineralization, the better off it's going to be. If you do rapid remineralization with things like high dose fluoride, we don't actually get remineralization going down into the body of the lesion. So I don't know how many of you actually read the October 2023 issue of JADA, but there was a letter to the editor in the October 2023 issue of JADA which says, It may be inferred that the American Dental Association would recommend against restoration with any tissue removal in the treatment of non-cavitated or initial caries lesions. I don't know if they posed it as a question, but they made it as a statement that this is what the Journal of the American Dental Association is saying, is that we should be inferring that the ADA is recommending against cutting teeth. Oddly enough, the editor of the journal responds with a letter saying, no, we didn't say that. In fact, what we recommend you do is go read our paper on that topic where we actually say that. But no, we're not saying that here. But notice that we now have had 3 entire issues of the Journal of the American Dental Association last 10 years dedicated towards caries management and actually being able to manage this disease in very unique ways. And we live in a time, in an age where you have payers who are actually trying to figure out how do we actually make this financially sustainable for clinicians to do in private practice. Now, when you do this, though, I really would like to challenge you to start thinking about the activity of the caries lesions in your patients' mouths. So realize an inactive lesion does not need your restorative treatment. Now, I realize in school we're taught G.V. Black's fundamental concepts of tooth restoration. And so one of those is to restore form and function, right? I get that. But if a caries lesion is inactive and arrested, it doesn't need you to surgically intervene and cut it off the tooth and replace it with an inferior to material to what biology actually gave the patient in the first place. And so as you're determining the activity of the lesion, the question becomes, how do you do that? Because if you take an Explorer and you poke it into a lesion, you might create a cavitation. If you rake that Explorer across the surface of the lesion and it feels like you're raking an Explorer across a glassy, smooth surface, it's an inactive lesion with an intact surface zone. And if you're trying to remineralize that lesion or you want to get rid of a white spot, well, think about trying to remove that surface zone with something like a quick phosphoric acid etch. But if you don't have that glassy surface and you rake an Explorer across it and it sounds like nails on a chalkboard, it sounds rough, please don't poke into it. You don't want to injure this thing. You just want to gently feel the surface of it and get an understanding for how rough is it. And if you find out that it's rough, well, now you have an active lesion. There really isn't an intact surface zone. That tooth is actively demineralizing. And I hope that you're on this webinar tonight to try to figure out, so what should I do to those to actually get them to arrest so that next time I rake an Explorer across it, it feels glassy smooth. And so that's what we're going to talk about. But remember the activity of the lesion. But please remember that no matter what you do to remineralize these lesions, what you're doing is not magic. So anytime you're engaging the patient in remineralization, please try to ask yourself, but what's the patient doing all this and during all this? Because what I want the patient to be focusing on, what healthy behaviors do I need to have in the future so that this this remineralization treatment that I'm getting today is actually going to last, because we're going to be shooting ourselves in the foot if we find out that remineralized lesions do in fact continue to decay. And then we're going to find ourselves in quite a quagmire. Now, there's a lot of research out there that tells us that remineralized lesions are more resistant to decay than lesions that are just going straight through the tooth without any stoppage. So remineralization does seem to provide us with lesions that are more resistant to decay, because when they do remineralize, we wind up with a really weird tooth surface, which isn't really enamel prisms. We kind of get this spackling effect. I'm going to talk a little bit more about that, because that's why it's so important that as we remineralize teeth, we want to go with a low and slow approach rather than a rapid, fast remineralize this tooth with as much calcium phosphate and fluoride as many of us used to think that we wanted to do, because we wanted to capitalize on the antibacterial effects of high-dose fluoride. But the point I'm trying to make here with this photo is that my patient, while we're talking about remineralization, my patient is making a goal to figure out, what am I going to work on before the next appointment? Because I know I'm successful if my patient remembers their goal. I'm not successful if the patient says, I don't know what you want me to do after. I forgot what I was supposed to do after this appointment. So always focus on what the patient's goal is. Now, my assistant Megan and my big challenge in practice is that I find myself saying things like, did you see Saturday Night Live? And when that happens, I realize I've really have lost control of the clinical situation. And what I really should be bringing it back to is this patient's oral health, because this is just the limited time I have with this patient. And so I have challenged my assistant, Megan, to stop the appointment and say things like, Dr. Novi, I have a question for you. And then I say, oh, really, Megan, what's your question? And she says, well, I have an oral health question. And I say, what's your oral health question? Now, we haven't really practiced it much beyond that, because then we usually stop and there's kind of some laughter that goes on in the operatory and whatnot. But then I'll ask the patient, does that feel forced? Does that feel canned? And usually the patient says yes. And But all I'm trying to do is just start a whole different kind of conversation. So the patient realizes, wait a second, what are the two of you trying to pull here? Well, what we're trying to pull is we're trying to get you to figure out what goal you're going to set so that before your next appointment, we're making a note in our computer software. What's the patient working on? Are they working on brushing once a day? Are they working on brushing twice a day? Are they working on flossing? Are they working on using fluoride mouthwash? Are they working on using the special toothpaste we're giving them? Are they working on changing their diet? Are they working to give up soda? Are they working to give up sugary snacks? Are they working to give up cereal? Are they working to organize family oral health time at night? Are they working to try eating cheese after their meals? What are they working on so that we can capture that? But so when we ask the patient, I have an oral health question, or do you have an oral health question? The question is, what goal did you set before your next appointment? That's really the focus of that question, is what goal did the patient set? Because if the patient isn't setting a goal, well, then what's the point of even talking? I want my patients to set goals so we can capitalize on their small successes. Now, what do you have that you can offer your patients in the office to remineralize lesions? You got some of this goop, don't you? I'm sure you have a bunch of different brands of this goop, and you have tree sap with some electronegative anion in it, and your patients come in and they want their teeth cleaned, and then you say, now that your teeth are cleaned, I'm going to coat them in this sticky sauce, and you're going to go, I don't like that stuff. It's just sticky. And I'm going to say, it's good for you. It's like cauliflower. Now, granted, yes, I realize there are fluoride varnish protocols, and as the president of the National Camera Coalition, I know how many of you feel about caries risk assessment. You probably dislike it as much as I do, but you know that caries risk assessment leads you to some appropriate fluoride intervention. And of course, I don't want to say don't follow the evidence-based clinical practice guidelines, which actually speak to this is the amount of fluoride these at-risk patients should be getting. And so let's be honest, our highest risk patients should be getting fluoride varnish applied to their teeth about every 3 to 4 months, until they're considered low risk. Now, the problem with that is, in my opinion, we put patients in a penalty box and we start making it all about, well, you have to go a certain period of time without getting caries lesions. But if you have more than 6 filled surfaces, you're already high caries risk. And then how do you justify putting fluoride varnish on a low risk patient to keep them low risk? And so we can massage all these nuances of fluoride varnish recommendations if you want, but now is not the time or place. I would just point out that on page 1 of the Journal of Dental Research in 2015, page 1 of the Journal of Dental Research in 2015 says, in the presence of biofilm, plain old sodium fluoride application resulted in net demineralization. In contrast, nanohydroxyapatite treatment reduced demineralization, and the presence of biofilm enhanced the effect. That was on page 1 of the Journal of Dental Research in 2015. So let's break this down, folks. Do you think that the editor of the Journal of Dental Research picks and chooses very carefully what's going to go on the very front page of the journal that year? And why would it be that in 2015, the editor of the Journal of Dental Research decides that page 1 is going to say, if you leave biofilm on a tooth and you put plain old sodium fluoride on top of that biofilm, that can result in net demineralization. Now, we understand this to happen. We know that this happens. We've seen it happen in research. Up until 1995, there was a phenomenon in the literature called occult caries or hidden caries or fluoride caries, which is the caries process that results from the over misuse of high dose fluoride when you put it on top of acidic plaque. Because when you put fluoride on top of acidic plaque, it turns into hydrofluoric acid. We know that hydrofluoric acid is produced because we know that that's how it has to cross the cell membrane of Streptococcus mutans to kill it. So once it's inside the bacteria, though, those two ions disassociate. So you have an extra proton and you also have a fluoride ion. The fluoride ion interacts with the enolase enzyme in the glycolytic pathway. So it stops glycolysis. The extra proton now that you have hanging around, that acidifies the inside of the cell. And now you have now dropped the pH to a level where glycolysis cannot occur and none of metabolism can occur. So this bacteria fails to thrive. But no one ever stops to tell you, well, okay, now all that has happened. What happens to all this fluoride and protons that are hanging out in dead bacteria? Do you think that the laws of chemistry just all of a sudden don't apply to them because the bacteria is dead? No. Fluoride is always going to find that proton. It's going to create hydrofluoric acid, and we wind up with a bunch of dead bacteria swimming in a matrix of hydrofluoric acid, and we wonder why we get these lesions on these teeth that we think we're going to go in and do a sealant. You drop into this little sealant effect or this little caries affected groove. Next thing you know, you're doing a pulpotomy or worse. And you thought you were going to do a sealant. So all that to say, and I realize people look at this and go, well, so we should be using nanohydroxyapatite. Well, I would be very careful what you read into this paper, because notice this paper it's not a paper about nanohydroxyapatite. This paper is about the fact that biofilm layers affect our treatment outcomes. We need to pay attention to the biofilm that's on our patient's teeth. I know that there are very well-intentioned clinicians who are involved in fluoride varnish application programs where they go in and apply fluoride varnish to kids' teeth. I love that idea, but please, if you're going to do that, follow the ADA guidelines and get those teeth squeaky clean before you do that, because no one has ever told you that you should be putting fluoride varnish on top of plaque. And in light of this paper, notice that if you're using the cheap old fluoride varnish with no calcium and phosphate in it, and you put it on top of biofilm, it can cause demineralization. So please, for the love of all things that are holy, remember the fact that you need calcium, phosphate, and fluoride together. Calcium, phosphate, and fluoride together in biofilm produces remineralization. But if you just put fluoride on top of acidic biofilm, it turns into hydrofluoric acid. So let's bring this clinical, because this actually plays out in our patients' mouths. Now, if you know me, you know Eddie. I've been seeing Eddie since he was 3 years old. Eddie's now 17 years old, and Eddie came to see me with a problem. He was 6, which was white spots on his front teeth. His mom said, "Can we bleach those white spots?" I said, "No, why would we bleach those white spots?" Well, folks, can we just be honest for a second? Carbamide peroxide is a great anti-caries agent. So if you don't realize that, please, I beg of you, take a class by Van Haywood on bleaching trays and how to use bleaching trays to treat caries, because it's a wonderful technique to use 10% carbamide peroxide to treat caries lesions. We obviously didn't bleach Eddie's teeth, but people question me all the time. How do you know that that's a white spot on the distal of 9 on Eddie's tooth? And I apologize to our friends around the world who don't use our universal numbering system. In fact, you would disagree that it is a universal numbering system because we only use it in the United States. So I realize that tooth is probably, I'm gonna show my ignorance here. Well, let me just say, I know that it's the maxillary central incisor, and the distal surface of the maxillary left central incisor has a caries lesion on it, because if I have an area of plaque stagnation and a white spot forms under that area of plaque stagnation, I call it a caries lesion. And so we set about trying to remineralize Eddie's central incisor, and Eddie then went through ortho. Now ask yourself, what genius in their right mind would even consider giving a Medicaid patient with white spots on their central incisors full brackets in ortho, right? Who would do that? But we made it work with Eddie. And it didn't take that long either. And we remineralized his central incisors. Now, this is my problem with caries risk assessment. We put patients in this penalty box and we say, if you've had a caries lesion last 3 years, you're still high caries risk. Please don't put patients in penalty boxes. Just because it's on a caries risk assessment form doesn't make it scientific fact. That's just simply an idea that if a patient has not really had their caries risk addressed, well, they probably are still high caries risk. So they might be high caries risk for 3 years after the last restoration. I really hope that no one on this call is the type of clinician who's not doing any sort of disease management. And so consequently, you wind up putting this patient in a penalty box and you say, no, I'm not going to lower your caries risk for 3 years until you prove to me that you're healthy but not getting any caries lesions. You can reduce the patient's caries risk overnight just by getting them to improve their oral hygiene. So celebrate those little successes, and please don't put patients in penalty boxes. And for those of you that are text messaging me on my cell phone saying, "Hey, I'm listening to Viva Learning," I appreciate it very much. Although it's it tickles me that you're text messaging me, but I'm watching the Q&A on Viva Learning, and so I won't be responding to your text message questions. But I do appreciate the fandom that's out there. So people wonder, but what happened to Eddie's tooth? Well, 9 years later, we still did not have any progression on the distal of that central incisor. And in December of 2022, mind you, this is now almost 10 years after we started trying to remineralize Eddie's central incisors, he looks like this. Now, I would imagine that most of us who treat Medicaid patients, when their patients are 16 years old and in full ortho, you wouldn't expect their gums and their mouth to look like this. But that's what Eddie looks like. And he actually looks like this in real life. Eddie does exist. He is a real life patient. And we wrote a paper about how we got Eddie healthy. And so you can read the paper to figure out how we did it, but you don't have to read the paper. I'll just tell you. We told Eddie, hey, can you brush your front teeth? And the technique that actually worked, because Eddie didn't always have access to MI Paste. The therapy of choice that he liked was Melon MI Paste Plus. But at the time, we thought, wouldn't this be great if you could use it as a toothpaste? It wasn't available as a toothpaste. We were told you can't use that as a toothpaste, but Eddie really liked the mouthfeel of it. And so we told Eddie, we'll put it in your mouth and then brush it around your teeth. But I used to get phone calls from his mom saying, the pediatric dentist is out of MI Paste. Where can I get more? And so there were times when I said, just use regular old toothpaste and leave the toothpaste foam in his mouth. But at the end of the day, what got Eddie healthier? It was the fact that he had a parent who cared about him enough to document that he brushed his teeth every single night. And so every single night for more than 10 years, his mom has been documenting him brushing his teeth. And he has this photo collage. Actually, he doesn't have this photo collage. I have this photo collage that is thousands of pictures of Eddie as a little boy for 10 years, brushing his teeth every single night before he went to bed. And all that to say, you don't need to hold your child down and brush their teeth for them. You can simply supervise their toothbrushing. And in fact, we see this in the literature. We actually wrote about it in the systematic review published in the Journal of Dental Research, that simply giving a child low doses of fluoride and supervising their toothbrushing is an effective technique to keep that child healthy. We just have to engage with our patients in a little different way and convince them that this is something they want to do. I mean, wouldn't you like your patients to go to bed at night going, gosh, I really want to go stick that toothbrush in my mouth. And I really like the flavor of that stuff that they gave me. Oh, I can't wait to taste that. Oh, I can't wait to feel that on my gums. So I think Eddie's going to be a toothbrush model one day. And this is what Eddie looks like. I think he's the most bad. I wanted to say a word that I probably get in trouble for saying online. Look, he's making toothbrushing look really cool. And he's grown up with healthy oral hygiene habits. And he looks like this today. Now, I didn't give him fluorosis. The pediatric dentist and orthodontist did, but I would take that fluorosis. I would love that and have that little snowflakey pattern on my teeth, because you can't tell me that once we pop those brackets off, his teeth aren't going to sparkle like a diamond in the sky. So the reason I think this all works in practice is because I've shifted my questions that I ask my patient. I don't make the patient's appointment all about what's the matter with you. I make it all about what matters most to you. So I've got a limited amount of time with my patients. And for the most part, what I want to focus on is what matters most to you. What do you want to get out of this appointment? Do you want to get out of pain with this appointment? Or do you want to get out of here as fast as possible because you're so terrified of the dentist, you just simply can't stand being here any longer? Or do you want to have whiter teeth after today? Or do you want to stop do you want to make sure that you can eat ice cream after today? If we focus on what matters most to our patients, we will eventually get what matters most to us, which is that our patient gets healthier. And oddly enough, no matter how much we bark at patients about brushing their teeth differently, they don't. In fact, the easiest way to get a patient to not brush their teeth is actually to start barking at them and telling them, you need to brush your teeth better, brush your teeth longer, and start harping on them about oral health. So what I'm trying to say is, oftentimes in practice, when the most hindering thing to us in practice is actually when our patients actually hear a phrase from a very well-intentioned person on our team, maybe at the front of our office, who, as they're leaving, after they've had a great experience in the back, someone actually chimes in and thinks they're saying something helpful by saying, make sure you brush your teeth better after today. You don't want that to happen again like it happened, the other day. And it's that moment when those words fall on that patient, where the patient actually decides, I'm not going to change my behavior. I don't like the way you just spoke to me, and you've ruined all the rapport that was built in the back. And it's meant with the best of intentions, but if you don't actually focus on how our entire team communicates with patients, there might be situations actually happening in our office that are actually hindering us from getting our patients healthier, simply because our team doesn't know how to communicate with patients. And so there's a great book out there on this topic, and it's called Hypnodontics. I wouldn't normally plug a book, but Hypnodontics by Juan Acosta is a great resource if you're trying to figure out what are the language barriers that are actually affecting my patients, because oftentimes it's word choice that we use, or just simply not using the same language that the patient used with us. So I'll leave you with that. This is all about how to communicate with patients. There are some other great speakers. Make sure you listen to Todd Snyder. He's another great patient communication expert. But that's if you wanted to read a primer that Matt and I wrote about how to communicate with patients, we wrote it in this journal, and this is available online with open source. So what I've done in practice is I've changed really the way I interact with my patients. I don't walk around my practice thinking, how do I get you to change your behavior? I walk around my practice trying to figure out, what do I got to do to get you to change your behavior? What do I have to change about the way I'm interacting with you to want you to get to change your behavior? And so my patients set goals. I like my patients to write out their goals. Now, I don't expect everyone to get their elderly male patients to write goals on the tags of fuzzy little bacteria and say that they're going to remember to brush their teeth. But a lot of patients actually do like writing out their goals. Adult patients find there's tremendous value in writing out their goals. If you do this, please do not harp on your patient's spelling. You're not here to correct your patient's spelling. What you're here to actually do is actually just incentivize them. This patient's goal is to drink 1 Mountain Dew, a mini can, during mealtime. And people say that's an inappropriate goal. Well, what if I told you she drinks 12 cans of Mountain Dew a day? She wants to give up Mountain Dew, and now I'm telling her, look, you don't have to give it up altogether. I realize how hard that's going to be, but if you confine it just to mealtime, you won't do all the damage to your teeth. It's when you sip on Mountain Dew throughout the day in between your meals that it really causes a problem. By the way, for those of you who know me, you know what a sugar addict I am, and I recently did a detox, and you'll be happy to know that I have given up all forms of soda, not the dog, the liquid beverage, and I'm now off soda. I'm going almost 3 weeks without having any soda. No, I'm sorry, 2 weeks. I know you're all super excited for me. So watch this space. Come to our lectures. You'll know if I'm drinking a Coca-Cola in the afternoon if it really worked. But I'm all about fruit infused water now. So we've known for a long time that you can't actually have sugary beverages. You can't have sugary snacks. It's the in-between meal and consumption of those sugary beverages and sugary snacks that cause the problem. You have all the sugar you want with your meals, just limit it in between your meals. So how do you actually measure this in practice? Because if you don't actually measure remineralization in practice, how do you know it's working? You've got to have a way to track this, because red spots on odontograms don't tell us anything. It doesn't tell us if lesions are progressing, arrested, if they reach the dentin, nor if it tells us if they need to be restored. So you can use something like the ICCMS system, or the International Caries Classification and Management System, or that's right, George. I gave up root beer. I see it coming through on the chat. I have given up root beer. I have not had a can of root beer in quite a while. And those of you who know me, you know I have a very soft spot for root beer. But nope, I'm off soda altogether now. I know you won't believe it, but yes, that's true. I'm off soda. So anyway, if you're using ICCMS to track lesions, that's great. A lot of people don't use it because it's kind of cumbersome to use. But let me calibrate you to it. If you dry off a tooth and you don't see any grooves, you have a healthy tooth. There's no caries affecting that tooth. But if you start seeing grooves, this is an ICDOS code 1 lesion. If it gets a little bit dark and you can see it on a wet tooth, that's an ICDOS code 2 lesion. And these are the types of lesions that we need to realize we can, they haven't actually penetrated more than halfway through the enamel. And so we can remineralize these things. And when we remineralize them, they become caries resistant. And I apologize. That is my other soda. Actually wanting to be involved in the lecture. So I haven't given up all forms of soda. The dog soda still is in my life, but the liquid soda is out of my life. And so these ICDOS code 1 and 2 lesions, if you don't cut soda out of your life, they're going to progress. But if you try to remineralize them, they turn into arrested ICDOS code 1 and 2 lesions because they haven't actually penetrated all the way through the enamel. And so if you get to an ICDOS code 2 lesion, that's where you see it turning dark and stained. And that's an ICDOS code 2 lesion. I would personally clean that out and seal that up. But when you get to this ICDOS code 3 lesion, when you start to see white demineralization extending away from a darkly stained groove, now we have an active caries lesion that you are justified in actually going into that lesion with a drill down the mineral mother dentin and restore that lesion. And I don't know if you want to do that. I start getting chicken skin thinking about that, going, did I do everything I possibly could to remineralize that lesion? And so if you're in practice and you wrestle with these kind of things, realize that the Canberra Coalition is a place where we want to wrestle these things with you. And we're more than happy to have you come to our meetings and we can talk about them. Get in contact with me or the National Canberra Coalition, and we can get you invited to one of our meetings. We meet every second Monday of the month at 7:30 Eastern time for 1 hour online. But the ADA Caries Classification System is a much easier system to use to actually measure remineralization in practice, because we break down lesions not into 7 different categories, but into 3 different categories: initial, moderate, and advanced lesions. So let me calibrate you to the ADA Caries Classification System. If you dry off a tooth and you don't see any grooves, you have a healthy tooth. If you don't dry off a tooth or you start to see grooves in a tooth, you have an initial caries lesion. But if you see a shadow underneath the darkly stained groove, now you know that the dentin is actively involved in the lesion. We have a moderate lesion. The tooth has not cavitated, but it's a moderate lesion. When the tooth actually cavitates, you have an advanced lesion. And of course, you got lots of different shades of gray there, which tell you when to stop sealing and start restoring. But remember, these initial lesions, we can seal them when we can restore, we can seal them and remineralize them. And I would even say there are people out there, dare I say, trying to remineralize moderate lesions with things like smart restorations. So watch the preventive dental world, because we're gaining more and more traction with chemical arrestive caries lesions and just entombing bacteria in the tooth. I'm not telling you to do that here. I would say follow the evidence-based clinical practice guidelines to figure out when and where to pull that trigger. We have some consensus documents that will help guide you, but now is not the time to get into a debate on how much decay you can leave behind in a tooth. But we do have these documents, like this document from Advances in Dental Research, would tell us that all clinicians Every dentist should be aiming for lesion arrest and inactivation of lesions to preserve dental hard tissues and avoid initiating that restorative cycle, because we all know the moment you touch a tooth with the drill, you've doomed that tooth to be drilled on for the rest of its life. So how do you select your therapies that you're going to offer to patients? Now, I've told you in the beginning, I don't want to make this all about the therapies, but are you truly beholden to the most electronegative anion in the periodic table, or are you willing to actually say to your patient, look, there's some other things that we use these days. Now, the question really becomes, I think, in a clinical practice, how do you wrestle with the anti-fluoride patients? Because that's really, isn't that really where many of us meet our biggest challenge? Now, I'm going to tell you the way I handle it. You say, I get it. I totally understand. We don't have to use fluoride. I read a lot of scary stuff about fluoride online. If you don't want to use it, I totally understand. May I just have your permission to bring it up again if in a couple months I notice that what we tried isn't working? And if you say, no, you don't never want me to bring it up again, that's totally fine. I just would like to make a note in your chart that I asked you if it was okay to bring it up, or if you want me to never bring it up again. I can tell you that most of the time down the road with that patient, when the conversation is had, to say, what we tried didn't work, and I'm worried that your little kiddo is going to need a shot. We're going to have to do something more drastic on that tooth. Usually the patient stops me and says, Brian, whatever you want to do, I trust you. I'm like, well, I was just going to put just some special fluoride right on the tooth. Like, Brian, I trust you, whatever you want to do. Well, I remember that first appointment you said you didn't want me. Brian, we've known each other long enough. I know I can trust you, whatever you think is best. And they let me do what I know is best for their child, because I focused on what mattered most to them, not what was the matter with their thought process, not what was the matter with their water, not what was the matter about their philosophies about poisons. I focused on what mattered most to them, which was, I just want you to hear me out. And then in the end, when you have that rapport with patients, they actually allow you to do the things that you know are best for them. So what are you really trying to accomplish with your patient? Are you trying to accomplish just getting them in and out of the chair as fast as possible? Or are you trying to accomplish actually setting up some healthy habits for life? Because a long time ago, I read a paper in Critical Reviews in Oral Biology and Medicine where it very clearly said the technology with the most scientific evidence to support its clinical use is the remineralizing system utilizing casein phosphopeptide. And this was shortly after I graduated from dental school. So it's no wonder that I immediately started picking up MI Paste going, well, if Critical Reviews in Oral Biology and Medicine says this technology has the most scientific evidence to support its use, I want to be using this product. And so that's what we used to remineralize Eddie's teeth. Then I get asked to be part of a panel at the American Dental Association to review non-restorative treatments for caries lesions. We start looking at this product, and I'm part of a group of authors that write a paper where they say the panel recommends against the use of this. And I said, but I wrote a case study about Eddie's teeth remineralized with casein phosphopeptide. And I was told, congratulations, Brian, you have an N of 1. Come back to us when you have an N that's the same size as the N that we have for fluoride varnish. Now, here, I just want to point out to you, if you look really closely at this screen, this is the network meta-analysis for the volume of lesions which have been documented in the scientific literature as being arrested with chemical therapeutics. Fluoride varnish has successfully arrested 255 lesions. Acidulated phosphate fluoride gel has successfully arrested 604 lesions. But 10% CPP ACP paste has successfully remineralized 1,443 lesions. So I ask you, where do you see the volume of evidence? Is it 604 lesions, 255 lesions, or 1,443 lesions? And notice, this is not talking about 10% CPP ACP with fluoride. This is just talking about 10% CPP ACP without fluoride. So the question you must ask yourself is, well, why would they say this? Well, I don't think it's as nefarious as people want it to be. And I would love there to be some weird, wicked conspiracy theory, but I don't think there really is. I know because I was in the room when these conversations were being held, and we recessed and we had some very frank conversations. And the reality is, look, we want to make sure that patients have access to the most evidence-based therapeutic that will work to reverse caries lesions. We have a lot of scientific evidence. You may think it's not as high level as it should be, but we have a lot of evidence. It's hard to dispute the overwhelming evidence for the fact that 5% sodium fluoride varnish has an effect on caries lesions. We also have even more evidence that acidulated phosphate fluoride gel works really well. But if you look at this, we have even more lesions that have been arrested with 10% CPP-ACP. So it's not that it doesn't work. It's just that we want to make sure patients have access to something that we know is going to work, and they're not going to avoid getting something that we know will work more times than not, and instead pick up something which might not work as well as. But I want to point out and be very clear. Notice this is not talking about combination therapy, because when I start looking at data with combination therapy with CPP-ACP with fluoride, well, you can't really, there's really no comparison. So this all goes back to the fact that we've known for a long time that casein protein is actually caries protective. In fact, if you feed rats casein protein or cheese, they don't develop cavities. And it's been around for quite some time, and especially in Australia and on the other side of the world, they've been using milk protein to stabilize calcium phosphate and deliver it in basically a biological concentration that helps us rebuild the structures of the body. There's a great paper that came out recently. This is some in vitro research, but it's some really interesting research showing that when you alter the concentrations of casein versus fluoride, you get different remineralization phenomenon. And so what we see is that if you have a little bit of fluoride, you get some remineralization. If you have a little bit of casein, you get some remineralization. But it's the combination of casein peptide and fluoride that really helps you get better remineralization. And if you look at the systematic reviews in the orthodontic literature, they'll say these weird statements like there's little they don't say there is little. They say little scientific evidence to support the effectiveness of CPP-ACP. Notice they're not saying CPP-ACP with fluoride, and they're saying little scientific evidence. They're not saying no scientific evidence. They're saying there's a little scientific evidence that supports the effectiveness of this product. And so you see it mentioned in the systematic reviews. But if you look at the systematic review really closely, what do they say is the easiest way to prevent white spots in patients who are undergoing ortho? It says cement their ortho brackets with resin-modified glass ionomer and give them CPP-ACP with fluoride as a preventive product, because when you combine those two things together, it seems to prevent white spots better than anything else that we've got. So, friends, look no farther than the ortho literature if you want to find out how to treat caries. I believe that orthodontists are probably the experts in how to prevent white spot lesions from forming on teeth. And their literature is telling us when you use things like glass ionomer and a low-dose fluoride that has calcium and phosphate and based in protein, you don't develop white spots. And that's because you've got reservoirs. We're adding reservoirs into the mouth to hold these remineralizing ions. Composite does not add any sort of reservoir whatsoever. So the great thing about the molecule is that it's actually wrapping protein around calcium and phosphate, and it selectively releases calcium and phosphate at just the moment that you want it to, so that you don't have this rapid burst of calcium and phosphate. You get the slow diffusion of calcium and phosphate, which allows you to reprecipitate ions into a more organized structure. And it's all really about creating more organized structures, because in normal healthy saliva, which I don't believe very many people have, normal healthy saliva and normal, healthy, good biofilm that's on your teeth has, we know, fully phosphorylated serral cluster motifs of calcium, fluoride, phosphate nanocomplexes. And that's what helps stabilize the minerals on the surface of the tooth and the surface zone of the lesion. So I mentioned earlier in the call that one of the great things, or one of my mind universe denting concepts that I've recently become aware of, is the actual power of stannous fluoride galvanizing the tooth. Now, for those of you who don't know a whole lot about galvanization, but if you live anywhere near the water, I just came back from Hawaii where everything seems to rust. And they don't, and I asked, well, why don't you galvanize your metal? And they talked about the fact that, well, how would you galvanize this? I'm like, well, I don't know. I don't know how you galvanize something once it's actually on your house. But they talked about using this paste and rubbing off the oxidant, off the rust and the iron oxide layer. But when you galvanize metal and you entomb it in zinc, the metal doesn't actually corrode. And it's the same thing with your tooth. When you add the stannous ion to the tooth, you make your tooth much more acid resistant because you've saturated your tooth crystal in a metal ion now. Same way if you were adding glass ionomer to the mix with strontium ions, you're adding metal ions there. And it's those metal ions that make your tooth more acid resistant. So ask yourself, why am I putting electronegative anion here trying to make something more acid resistant when I can saturate the tooth surface with metal ions and make it more acid resistant? Now, that's the great thing about MI Paste 1 Perio is that it has stannous fluoride in it. Of course, MI Paste 1 for kids, well, the best thing about that is it's got blue raspberry flavor. Although I would like to know, why does blue raspberry flavor toothpaste come in only in the color white? I don't know, just something that keeps me up at night. So many people are asking me these days, okay, Brian, but I'm seeing all this stuff about hydroxyapatite toothpaste. What about nanohydroxyapatite? So I have to address the elephant in the room. We've known about hydroxyapatite compounds, and we've been trying to remineralize teeth with them since the 1980s. Many of you will remember early lectures of mine given in like 2006, 2007, where Novamin was a big product. Novamin isn't on the market anymore, but that was basically a bioactive glass that delivered hydroxyapatite, or ACP technology, actually, which if you're talking about nanohydroxyapatite or hydroxyapatite in general, you're really just talking about a ratio of calcium phosphate and fluoride. So what I understand from the literature is that particle size matters, despite what you may be hearing. Particle size and concentration both matter. So the particle size of your hydroxyapatite crystal, the sweet spot, according to science, seems to be 14 to 17 nanometers. And you don't want to have more than 10% of your hydroxyapatite in your paste. It seems like if you overwhelm the system with too much hydroxyapatite, you don't get that remineralization phenomenon that goes deeper into the lesions, which is what we want. I love the fact that the research talks about that it's hydroxyapatite lotions that are actually demonstrating efficacy. It's the lotions that we leave in the mouth over time that work, not the things that we're rinsing out. And also realize that most of this research on nanohydroxyapatite, it's all done in vitro. These are not in vivo studies. These are mostly in vitro studies. And in vitro studies are not evidence. We only consider randomized controlled trials in human mouths to be evidence. If it happens in a lab, that doesn't necessarily mean it happens in the mouth. Point of fact, why do we keep studying Streptococcus mutans? We keep studying Streptococcus mutans because Anton von Leeuwenhoek took a sample of plaque from his teeth on a toothpick centuries ago and plated it on a potato slice, and the potato slice grew bacteria that looked like a mutated bean on it. It was the first bacteria that he grew. We called it Streptococcus mutans. We still to this day keep growing it, even though it's not the bacteria which causes tooth decay. So we go down the wrong path sometimes. You can't just culture bacteria from your teeth on potatoes and assume that you're growing the same bacteria that causes tooth decay, even though all of our science for karyology is based on that fact. So please don't base all of your what you're using, the products you're using in your practice, on in vitro research. I'm not saying it doesn't work, but make sure that you have some products that we actually know are rooted in evidence. And I go back to page 1 of the Journal of Dental Research, where they say in the presence of biofilm, sodium fluoride application resulted in net demineralization, but it's the combination of calcium phosphate and fluoride which leads to remineralization. And the key takeaway message from this paper is not that it's about fluoride, but it's about biofilm. Please remember, at the end of the day, we want our patients to clean their teeth better. When we leave biofilm behind, we can reform that biofilm and make it better by making sure that biofilm has protein and some fluoride and some calcium and phosphate as well. But it's the biofilm that leads to this disease. And the biofilm chemistry is highly dependent upon our patient's salivary chemistry. And so if you want to change the patient's salivary chemistry, you may run out of products in your office. There were times when we ran out of masks during the pandemic, and sometimes you run out of your favorite remineralization agents. So what do? Remember that at the end of the day, you got to change your patient's diet. If you don't change the patient's diet, they're never going to shift the Riemann-Diemann balance in their mouth. So you may run out of products to offer the patient, but you can still change the patient's diet. If you can just encourage the patient to eat more protein and eat foods that bring down their blood glucose, like olives, for example. Olives are a food which actually lowers your blood glucose. Eggs are a wonderful source of protein, and eggs with more protein in the diet, more protein in the diet leads to more protein in the saliva, raises the pH of your saliva, allows your saliva to carry more calcium and phosphate to your teeth. Increase protein in your patient's diet. Please don't make this disease all about avoiding sugar. Our patients can have candy, they can have sugar, they can have it with their meals. In between their meals, if they increase the protein snacks that they eat, have protein shakes for breakfast, have scrambled eggs for breakfast, sip on protein shakes throughout the afternoon, or have a protein shake for lunch. Try to limit your in-between sugar frequencies and focus on foods that are rich in protein, specifically foods that are rich in one amino acid, which most of you know, in my opinion, is arginine. Despite the fact that there's no evidence for arginine in the diet, I will leg wrestle anyone. I will lose when I leg wrestle, but I will leg wrestle anyone who wants to challenge me that more protein, specifically arginine in the diet, would not help reduce tooth decay. Prove me wrong on that. I would love for you to prove me wrong on that. So I'm going to leave you with this. I think the day is surely coming, and perhaps within the lifetime of the clinicians that are on this call, when we will be engaged in practicing preventive rather than reparative dentistry. And those are the words of G.V. Black in 1896. I actually had included some of his original quote there for you, but I realize we have 21 questions. My cell phone is blowing up with people text messaging me. And so I'm going to go to the Q&A, and hopefully I can get through the Q&A. I see that people were expecting me to be muzzled. You are welcome, Dr. Wilkinson. You kept mentioning acid. Couldn't a patient just carry around a bottle of baking soda solution and rinse with it regularly? There's a novel idea. Yes, absolutely they can. The question is, how long will that baking soda solution remain baking soda before it turns into just a urea and ammonia solution? Because it tends to turn into urea and ammonia, especially if you're backwashing into an introducing bacteria. But that's okay because it's still pH neutralizing. But it just becomes very unpalatable at that point. So if patients want to do that, I like the baking soda lozenges, like Nuvora lozenges. That's a great way to keep baking soda in your mouth long term. Those things last like 24 hours if you use them the right way. Someone is asking me, are you a fan of brushing with MI paste or using it in a tray? It depends on the acid challenge. If they have a severe acid challenge, well, first of all, let me say this. If they're putting trays in their mouth, I want them to put MI paste in their mouth first, lick it around. It's MI paste plus mostly. Get MI paste plus in your mouth, lick it around, and move that everywhere. Saturate all your surfaces with that stuff, and then insert the trays so that your teeth are bathed in that remineralizing elixir. Don't just put trays in your mouth and cut off all the salivary flow to them. If you have stomach acid and you're dealing with regurgitation, oral health trays with MI paste at night are the way to go. But I am a huge fan of just using the MI paste toothpaste, MI paste 1, specifically MI paste 1 Perio, specifically because it has stannous fluoride in it. Laura wants to know why eating cheese after meal is recommended, because cheese is the natural form of MI paste, and it's that casein protein in cheese, which is what we're getting all of our great calcium binding chemistry from. Just curious, what was your point by asking patients if they're eating cheese after their meal? Well, Dr. Patel, the whole point was just to see if they understand that after a meal, they go through a state of demineralization, and there are things that we can do to actually raise the remineralization potential. What armamentarium do you recommend for effective biofilm removal? I am a huge fan of using Live Fresh gel on a Curaprox toothbrush these days. I love the Curaprox 1006 with a little bit of Live Fresh gel. That's actually replaced Prophy cups, in my opinion. I recently landed in an office where we're doing guided biofilm therapy, and that has changed my world. I love GBT. If you don't know what GBT is, get out from underneath your rock. And I'm sorry, that sounded. I shouldn't have said it like that. I was underneath a rock. My hygienist opened my eyes to GBT, and GBT. But my armamentarium for biofilm removal is a Curaprox Velvet toothbrush or a Curaprox 1006 with Live Fresh gel. And then usually after that, we floss. And then after that, I apply MI paste. We usually brush MI paste Perio. Again, I like that stannous fluoride. I changed my mind about sodium fluoride. All the cardiologists are all like gaga for sodium fluoride. But if you actually look at the research, it's all about stannous fluoride. So would nanohydroxyapatite such as Remin Pro be more of a rapid remineralization as compared to MI paste? I like both, but feel they should not be used interchangeably. I think they actually can be used interchangeably. I think really there's a different mouthfeel with each one of them. I love the flavor profiles of both. I think having both options available for your patients is just an easy way to cover your bases and make sure that if you do have a patient that has any casein allergy, you have something to offer them instead. I know it's the penalty box comments. Let's see. CC, Hypnodontics. The book is called Hypnodontics, Hypodontics. Hypnodontics is by Juan Acosta. It'll change your life. You got to make it through the first 100 pages first, though. Is it not true that brushing for an extended period of time can cause recession? That's a great question, Nicole. I have we can open up a whole can of worms and start talking about abrasion versus abfraction versus caries. If patients are brushing properly with a soft toothbrush, I'm not too worried about recession. I also think that tissue tends to follow bone. I'm not a periodontist. I know bad things happen to general dentists to become periodontists. The Q&A is just blowing up. I'm just gonna, Nicole, I'm sorry. I'm gonna have to put that in the parking lot. Yes, friends, I did actually give up. I still am truly off root beer. That's not a joke. Do you reserve the fruit-infused water to meals only? Do you have any recommendation for people who sweeten with monk fruit juice? Oh, I hate monk fruit juice. I don't know why. Okay, sugar is organic and it's natural. Why are we, if you want to sweeten something, use organic, natural sugar to do it. I know recently I haven't been doing that. we've been using honey. But I'm just doing fruit-infused juice, my fruit flavor of the day, and I have been sipping on it through the day because I like to sip on beverages. I know it's still acidic, but heck, it's better than me sipping on Coca-Cola. So my fruit juice of today is passion fruit, star fruit, lychee juice today. Okay, so what's the best difference to tell between decalcified enamel and calculus to ensure we don't scale off decalcified enamel? Thank you for that question. That's the best question I've gotten. If you even think you have decalcified enamel, please be very gentle and just brush that very, very gently, and then ensconce that in some glass ionomer of some sort, like any really flowable glass ionomer, like a glass ionomer sealant material or glass ionomer bonding agent would be great. I think we are out of time. I'm not entirely sure how long they're going to keep me here, but I do believe that we are down to 1 minute. And I'm sorry, folks, the questions are just flying in right now. So I guess the last question is, as a follow-up, when should you recommend MI paste, regular versus MI paste? If I recommend, if I want to try to remineralize a lesion, I gravitate towards MI Paste Plus because it has a little bit of fluoride in it. But the one I'm gravitating towards more and more these days is MI Paste Perio or MI Paste 1 for kids, because it combines everything into one step. With that, folks, I have to go. Thank you so much for sticking around. I'm sorry for going over. Good luck on your quiz. I wish you all the best of luck, and take care.